Hi everyone. I think we are the panel between the lunch and you, right? But just on AI, that's my AI generated image of how I will look 5 years from now, right? So don't get confused or carried away. But I think this is a very important question because now AI is not something which you have a choice of, right? It's an eventuality which will happen, right? And Dileep mentioned about a few things, so I'll pick up from there, and I have of course an august panel of people here who are specialists in their field, so we'll pick their brain on a few things to and also some takeaways. So let me start by sharing one incident which happened a couple of weeks back. So I was trekking in a place in Uttarakhand called Chakrata. And while we were trekking, one of our fellow trekkers, he actually slipped because it was raining. So it was slippery. He slipped and got a deep cut on the forehead and started bleeding. We were at least, I think, 60 kilometers from Mussoorie. But the trek guide or the trek leader who was there, he said that no, there is a PHC nearby. So he arranged for a bolero to be made available 3-4 kilometers from where we were. And we took that person, and because I was a doctor, the trek lead said that please accompany, so some help can be done, and if there's no one available, probably I can also do the stitches. So we went to that PHC. The PHC was locked, right? PHC, Primary Health Center. And fortunately, the caretaker quarters were within the premises, so that is the good part. So we knocked the gates, the caretaker came out, and we said, can you open it up? He said, we don't have a doctor, we don't have any paramedic. But we said, okay, because I'm a doctor, I can look at what all supplies you have, and if some medicine, something, dressing that I can use to help my my fellow trekker. So this took 15-20 minutes, half an hour. This word that I am a doctor started spreading around, right? So word of mouth, mobile phone. And in an hour or so, while I started looking at the supplies, started looking at the equipment, most of which was rusted, there were 8 or 9 people who had queued up outside, just hearing that there's a doctor who has visited the PHC, right? And then I came to know that for the last 2.5 years, no doctor has visited that PHC, right? Though it was well equipped, good building, because of the funding, government, everything. Some CSR funds had, stacked the pharmacy and equipment, but most of the medicines were about to expire. The equipment was getting rusted. Autoclave was there, but was not functioning. So when we talk about AI, when we talk about accessibility, I think this is what we have to see how we can address, right? Mr. Sanjay Khosla of Sun Microsystems made this epic statement that AI and machine learning and everything will make 80% of the healthcare providers or doctors redundant. I think in India, I think AI will help 80% of the underserved population get access to quality healthcare, right? So I think those are some backgrounds, and with that, I want to hand it over to the august panelist here to share their thoughts in terms of what should be our strategy around AI, what are the challenges, what are the new things that we see, and probably we can start by one example, right, of how AI is being used in healthcare that you can share, and then we can move on in the session. I see the clock. I don't know, you don't see, so I'm stressed, like Vishy had mentioned earlier, but I think we'll have some buffer. So let's be crisp, but at the same time share some meaningful insights with the audience.
Start with one example how India is changing. How many of you know that TB is still one of the biggest killers worldwide? I think at least one hand, few hands have gone. Oh, more hands. Today there are 11 million patients, active patients in the world, and 25% of these patients are in India. And it's not 40% of the people, if you test, you will be carrying a TB bacteria. And what has changed? There was a target to eliminate TB from the world by 2025, which has not happened. and new target is now 2030. And what is changing in terms of using AI is it was very difficult to really screen people in villages. I had a chance to visit at least 3 TB camps in Uttarakhand and in South Karnataka. And I had a chance to look firsthand how technology is being used. You know, today the low cost portable X-ray unit, which is as small or as big as a DSLR camera is used to really capture a chest image. And this is used in combination of AI to screen a patient for anyone having a positive TB. And then he's going for a diagnostic test, which is also done very quickly, collecting the sputum and being done, which earlier was not possible. And today, almost every TB camp, every day, there are many TB camps happening and technology is being used. This is a brilliant use of technology, and this is being done worldwide. World Health Organization has approved use of AI for screening, which was not the case earlier. So that's a big example.
Well, he's already used X-ray. Almost, we've become the backend for X-ray reading now. And with companies like Siemens, they're working so hard. I mean, people will realize that Siemens or any of the other health tech companies, are now more of digital companies, less of the core strength that they have. And we work with the startups of the world. I will come to the problems that we face so that we have something to work on it. We see there is still, though engineers and doctors are talking for last 5-6 years, but I think there is still a lack of understanding. Talking is different from the lack of the understanding. And we see that maybe upscaling of these professionals on both sides of the boundary have to be done. And AI will help them. Of course, in the AI, this doubt should not remain there at all, that is AI helpful or is it useful? It's getting into almost everything that we're talking in healthcare. There are 200 use cases we work on with the startups. Almost 70% of them use AI in some way or the other. So this is happening, and we see that if we can take care of this upscaling using Gen AI, for example, magic can be created. Unless till then, I think people have to start marrying doctors and engineers, vice versa. That's the only option available.
Yeah, we think of AI in health broadly in 4 buckets. One is population scale data and AI. Think of the stuff we heard during COVID, predicting where the hotspots are going to be, how many ICU beds are required, so on and so forth, right? That's population scale AI. Second is individual level AI. This is what we tend to think about when we say healthcare. Take an image of something, do you have TB or not, right? Or predict whether or not you're going to develop certain conditions later, right? Could this lesion in the mouth turn into oral cancer, later? That's the individual level AI. The third is natural language and generative, now what we are calling agentic AI. Think of this as a substrate for both population side, population scale AI, as well as individual level AI. Natural language AI is all about understanding the situation, collecting the information, and responding in a way that's safe and responsible, right? So that's the third layer. So we work in all 3 areas. The fourth area that's emerging strongly now is robotics in healthcare. So while we work with, for example, Google here on Indic language data to really enable that natural language, spoken, multimodal kind of solutions as an open source data initiative. We also work with some cutting edge robotic surgeons, right? Surgeons themselves are not robotic, I should say. Cardiac surgeon who do robotic surgery, building digital twins. So we have, I think the challenge for India is, challenge as well as the opportunity for India is that we have at one end, we have to still meet the most basic needs, right? And as the health system digitizes, that spoken language interfaces are a must for inclusive health. At the other end, India can also be the substrate on which global innovations such as robotic surgery, right? Just yesterday we had this, we enabled a collaboration between, no, this is not workshop. This is real, basically a cardiac surgeon sitting down with a material scientist with a robotics specialist in Europe, right? And a compliant mechanical mechanisms researcher here at ISC. And we are together figuring out how to build some automated robotic surgery solutions for cardiac surgery, right? So I think this is the challenge of India, and I think the more nuanced we are about the fact, look, this kind of AI requires this strategy, this kind of AI requires this strategy. And I think that's what we find is most crucial. And for all of this, we get excited about the AI solutions. We tend to focus, okay, to build AI solutions, what systems do we need, right? Sorry, I took some time, but I wanted to lay out the spectrum a bit.
No, thanks, Raghu, for that. So, see, a couple of things. My company has three parts. One part is that we have an EMR or an HMIS, right, which we have been building. The second is services, third is insurance. Earlier in the day, there was talk that if we talk about technology budget with hospitals, right, they say 20,000, right? If we compare to US, where also we have our products, usually the technology budget is 2.5% of the overall top line of that hospital or that healthcare system. So there are challenges in terms of digitization or the digital journey of the healthcare providers or the hospitals. Why I bring this example up is that let me put it like that data, they say, is the oil, but I think data is a new soil on which AI does the farming. Would that be a good way to put it, Mr. Raghu? Right? So if you don't have data, the AI will not be able to farm or create any solutions, right? So what do you see, some examples on how we can overcome this challenge in terms of getting data? In the morning, Dr. Uma also mentioned about India-specific data, right? And also then within the constraints of being ethical, having the right frameworks, because we are dealing with health data, privacy, right? So how can we actually, create frameworks which incentivize, digital health incentive scheme was launched by the government 2 years back with the 50 crore purse. I don't know how that has been utilized. So what are those suggestions from you which we can share with the audience to see that, yes, we start collecting the data, and then the next step in terms of the AI models or the agentic models we can build on top of it. So
get on the ABDM, monetize private data. Data, if we cannot generate and use it, thanks to our population being the biggest now, we'll be fools if we don't use it. If we do not have the data, there's nothing else can be done. And fortunately, we have all types of diseases. Fortunately, we have a big talent pool of all the professionals on both sides, the engineering side, the AI and the medical. There's a lot of discussions happening on how we can monetize data, not only the Sarkari free data, but unless the monetization happens, will not move on.
Any examples where you've seen this monetization
happening? So we are working with the India AI mission. One of the pillars is for data. The other is if we have data, we have the AI engines working. Are we just talking or are we seeing some impact? So the one part of the pillar that we are working on is the deployment of these AI solutions. And that will give us an indication of what are things working, what are not working, what are the challenges. So things are moving in the right direction, I must say.
Okay. So Dileep.
One of the biggest challenges, everyone says a lot of data available, but if you look at the data, it is not structured. It's not annotated. It's not anonymized. And that data cannot be used. If you look at any of the good companies who are trying to work on any of these solutions, they need a data which is structured. Today, if you go into any hospital, they say, I will give you data, but none of it is available with patient consent, which is one of the biggest challenges today. None of it is annotated, and you won't know the historic data, connected pathology data, because if you want to build these solutions, it needs to be done with that. So without that, it becomes very challenging. Today, in Siemens Healthineer, we have collected nearly 2 billion data, patient data. But of that, only about one eighth or less is annotated and completely ready for use. We are continuing to do that. We have nearly 100 people annotation and building that structure into that data. But it's a huge challenge. And for that to happen, we need to really work with various hospitals. While monetizing happens, but if you don't give a right data, it can't be monetized. So these are some things that need to be worked with each one of the hospital, because as we move into ABDM, these become one of the biggest challenges that we need to work.
And this lack of data onion needs to be peeled just a bit, right? Because we say that, we don't have data, right? It's like water everywhere, not a drop to drink, right? So first, let's understand the purpose. So you might have water everywhere. You might be able to use it to flush your toilet, but not be able to drink it or give it intravenously. First, so purpose appropriate data is what we are all craving, right? So now let's talk about purposes. AI lifecycle, broadly 5 stages, right? First is discovery of new patterns, right? There you want maybe not many people's data, but very rich data. Maybe you want thousands of variables per each person. You're trying to find some new patterns, right? Then there's development. We think these 10 variables are useful. Let's try to reproduce those results consistently again and again, and know that we can actually build a solution on top of it. That's the development. Then someone needs to validate that, right? 5 people might have developed a solution. I need to be able to say, okay, this works, this does not work. So there is some kind of benchmarking or validation that's happening. And even after validation, every state, city, or for that matter, hospital will tell you they won't feel comfortable using it without local validation and adaptation. That's use number 4. Number 5, after you deploy it, continuously monitoring it, and if required, updating it. That's the 5th use of data. The challenge with, I think, all of this is all of these things require slightly different systems, data standards, mechanisms, and so on. So I think the conversation around data should shift from data to the systems. It's not the water. Yes, we want the water, but it's the standards of the water, it's the filtration system of the water, it's the source of the water, and they all change. And these are some of the things we are building with the likes of ICMR and many hospitals around India.
No, it's thanks. Thanks, Raghu, because we need to have the structured approach. Otherwise, we can always be caught in that whirlpool of, we don't have the data, right? And whether that's from a context of Indian context or clean data or annotated data. But how can we facilitate this acquisition? If there are some suggestions, we'll come to that as call of action. But before I go there, I think I'm already minus some seconds, right? I just want to wrap it up, and then we give the audience some time. Is the call for action to all the healthcare related experts, leaders who are sitting here? What would be your call of action to all of them?
I think my one action I would say is we need to work together.
Mm-hmm.
There's a saying, if you want to go further, you have to go
as
together.
A team together,
yeah.
Right? Walk together.
You walk alone. For us, I think this is very important. Unless we engage, collaborate with groups, if West has moved further, it's because they went together. We are still a lot working alone. We need to really go together.
Now this together, just to qualify, earlier it was said that there needs to be an industry, academia, partnerships, or there was that, doctors and engineers need to work together. So when you say together, it encompasses all of them.
Industry, hospitals, startups, government, you name it. Everyone who needs to play.
And like Raghu said, that a cardiologist, a material scientist, a robotic surgeon, and someone from Europe, right? All these different specialities
so that is
together.
A key thing. Yeah, absolutely. Yeah.
Okay.
Give some money into the system. Healthcare requires a longer duration. Put some genuine money. This is a high impact area. The government needs to put more money. Protection of IPs have to be there, which is happening. I mean, institutions are doing work, but we have to press the accelerator button.
See,
You're the
we
hands-on.
we grapple with this every day, so that's
Right.
why I'm kind of pulling at my hair, I guess. See, first is capacity and policy, then digital infrastructure, then you get data, then you can use the data, right? So the first thing I mentioned is policy and capacity. Actually, even before policy is capacity. So the biggest challenge, if you ask me, is the fact that we are separating math and biology in the 11th and 12th standard. We do not have math and data science as part of our MBBS curriculum, which means our doctors do not have deep enough depth left regarding thinking about how to use data in their interventions. So if there is one thing I would say, it is there is an amount of education required broadly for current professionals and our current medical system and administrator to really understand data and AI with a little bit more nuance. Otherwise, I think we come to these conferences, say very broad things, go away, right? So if I would say, let's invest in
Capacity.
that capacity of
Or
some
capability,
depth,
right.
depth. It's not good enough if I speak Telugu, you speak French, and we sit together, we can't have a conversation.
Right.
You need some ability to speak Telugu, I need some ability to speak French, right? So that's, to me, the crux.
Yeah, no, thanks. It's very important that we do that. So, couple of things. We'll open it up for any audience questions. Vishy, before we wrap up, any questions? Yeah, the mic, please.
Session before we go for lunch, so
Okay.
we need to quickly close this.
I'll feel less guilty with that. Thanks. Right, I'm not keeping people away from lunch.
Coming from US and having actively participated in the digital transformation of healthcare there, I think the question I have and something I would like to get your input on or your take on is, what do you guys think about the policy from the government side on HMIS systems, right? Because a lot of you mentioned the data is not structured. US went through that in the 2000s where they standardize a lot of things. Second is consent, which is a huge thing because today privacy and consent is just rubbed off. When you go to a doctor's office, everybody's listening to what's going on.
Right.
And the third is monetization. Who owns the data? Because is the ownership belonging to the tech company that runs the digitization? So just your take on those things.
Yeah, so Navratan sir or anyone. Yeah.
I think the policies have been very well taken. We have learned from what because we are the followers of some of the policies. I think we have learned the best of the different type of policies. In fact, there was just last week the third way of AI, which is the American way is the first way, the Chinese is the second way. We will follow the third way, which takes care of all these issues that have been raised. So being followers in policy making is definitely a positive thing over there. As a neutral platform at NASCOM, we have taken a lot of policy decision making inputs from the stakeholders back to the government, and because we are sort of blessed by the government, it's important for us to know that these policies will take time. Data annotation will require the doctors to be putting in their efforts. Money will come in if some doctors, some data generators will start doing it. We are followers and we'll see that money is flowing and things will happen. But the amount of money that will be generated, I think is a huge opportunity. Privacy and the GDPR issues, we are very well taken care. In fact, we get an international delegation every 5th day in our office, and almost every one of them have said our GDPR related or the privacy policy on the data is in the right direction. Execution is still a problem.
So just as numbers there. So like in US, the PMR or EMR penetration is 99.9%, right? In India, it is less than 20%, right? So what can be done to see that it becomes a mandate? Like in UPI, Aadhaar, right? Everything has, now everyone, the penetration is almost, up there. So what can be done to facilitate the adoption of HMIS, digital data? ABDM is there, but what should there be a policy which the government says is mandatory, either from a regulatory perspective or something else that tries to push this adoption?
Call the owners of the hospitals on the dais
Okay.
every third day. They will understand that there's a reason for them to get involved.
Right.
There's a money involved because hospitals will like to look at the money first.
Right.
And then, of course, what Dileep rightly said, who pays for it? But if you can prevent it, put the Ayurveda guys as well, so that they all talk to each other and prevent it much before the diagnostic path starts. I think there's a lot of room to play in that. And we are moving in the right directions. I think people who have been on the decision makers are in the right direction. It's just that the execution have to be done very well planned, and corrective actions will be taken care of. Things which we may not go in the right direction.
Thank you.
Thank you.